Oh, yes. Actually, get her up here. Yes, that's good. That's good. And you know what's funny is how everybody in the audience is smiling. Or at least a few of them. And Julie, you in particular. Okay, we're online. Welcome. We have a good crowd here at Virginia Hospital Center for our February program, which is on, put my button here, unequal treatment, how Arlington is addressing disparities in women's health. A big topic, particularly for Black History Month. And before we get to that topic, I want to just do the usual housekeeping items that I have to do. One is to let you know that in March 13th, our program is going to be on the impact of the arena, proposed arena on Arlington. It'll probably be all virtual, but tune in for that for March 13th. We are also, just as we always have to remind you that as a donor, you automatically become a member for the program year. And we could certainly use any donations you want to provide. We are an all volunteer organization at this point, and all that you see is being done by 20 people. So on our board, it's we can use all the help we can get for that. There is also the usual Q&A requirements here. When you ask a question, whether you write it online or you ask it here in the room, please make your question a question and not a diatribe of your interest in what the question is all about. We really want to have as much time as possible to get to as many people as possible, so we need your help in doing that. And then let's see, I want to thank the board of directors that were here tonight and are helping us out for this program. Karen Bate, Daniel Sanchez, who is in the back of the room. We have, let's see, who else? Oh, John Weistat, Jerry Laporte. Oh, Jerry Laporte, what did he do? No, just the people that were involved in the program. So I think, and Tony Weaver. So those are the people that really put their hands on to get this program put together. I also want to mention that a big thank you for the Sushi Zen and Lebanese Taverna, who donated the food tonight. And I hope all of you will get a chance when you leave to have some of that food. And there's still plenty out there, but you can't eat it in here. So just eat it. If you do, be very quiet about it. I'm going to now introduce Krista Jones, who is one of our newer members of the board. And I wish I could spend about half an hour telling you all the incredible thing that Krista has done in this community and for this community. She is, more importantly, one of the Women of Vision Awards from the county last year in the nonprofit area. And she is the author, the executive director, the producer, and the moderator for this program tonight. So please welcome Krista Jones. Oh, it's right.
Well, thank you so much, Jean. As Jean mentioned, I am one of the newest board members for the Committee of 100. And it was interesting because last year at our retreat, we were sitting around trying to figure out which topics we wanted to focus on. And I'm on the program committee. And something that we really definitely wanted to focus on was the idea of women's health and the disparities around women's health, because nationally, that's a huge issue. But of course, this is the Committee of 100 for Arlington, so we had to make sure we had an Arlington focus. And it was interesting how the program really evolved. At first, it just seemed really broad. We weren't sure exactly what we were going to focus on. So tonight, we're going to try to get into a lot of different pieces, but we really want this conversation to continue. And something that was really important to us, as usual, even though we're not an advocacy organization, that we do talk about things that could possibly be done to fix this major issue. So we are so thrilled to have our panelists with us tonight. I'm going to introduce each of them. They'll come up and speak for 15 minutes each, and then we'll open it up to Q&A. And so first we have Dr. Ruben Varghese, who promotes disease control and prevention and overall community health as chief of the Public Health Division of Arlington County. From 2000 to 2002, he was an epidemic intelligence service officer for the Centers for Disease Control and Prevention. While at CDC, he was part of a team sent to New York City to monitor latent health effects caused by 9/11, an asset to a community such as Arlington, which also was directly affected on 9/11. Prior to his work at USDA, Dr. Varghese was director of the Three Rivers Health District based in Middlesex County, Virginia, from 2002 to 2004. He received his medical degree from Brown University and has an MPH from the Johns Hopkins University School of Hygiene and Public Health. Please welcome Dr. Ruben Varghese. And next we have Dr. Denise Bruner, who is a nationally recognized expert in obesity medicine. Like her father, Dr. Roland Bruner, she graduated from Howard University College of Medicine in Washington, D.C. After completing her residency in internal medicine at DC General Hospital, she reopened her beloved father's general medical practice in Arlington, Virginia. Dr. Bruner has risen as one of the nation's leading authorities in obesity medicine. In addition to having a thriving practice, Dr. Bruner regularly lectures and speaks at medical education seminars and conferences, taking an active role in education and mentoring healthcare professionals around the world. She is also a frequent guest on both television and radio programs and has been quoted in numerous publications. Please welcome Dr. Denise Bruner. And then we have Dr. Patricia Mwasegwa. Dr. Mwasegwa is a transplanted Texan who completed her OBGYN residency at MedStar Georgetown University Hospital, Washington Hospital Center, and VHC Health. After residency, she completed a 3-year fellowship in female pelvic medicine and reconstructive surgery within the Department of Urology at UCLA. She specializes in incontinence, pelvic organ prolapse, and pelvic floor dysfunction. Dr. Mwasegwa is skilled in fistula repairs, managing complex voiding dysfunction, and performing both native tissue and grant-augmented pelvic reconstruction. Please welcome Dr. Patricia Mwasegwa. We also want to mention, Jeannie mentioned while I'm getting up their slides that we do have several partners, but this time we also added some community partners. And it was great because a lot of these organizations who partnered with us do a lot of grassroots work around women's health in Arlington. So I'm just going to read all of the partners again. We have VHC Health, Arlington Free Clinic, the National Coalition of 100 Black Women Northern Virginia chapter, Alpha Kappa Alpha Sorority Incorporated Zeta Chi Omega chapter, the National Council of Negro Women Northern Virginia section, and then we already mentioned Lebanese Taverna Market and Sushi Zen Restaurant. So let me pull up Dr. Varghese's slides. Welcome him to the podium.
Good evening. Can you hear me? Okay. I'm Ruben Varghese, as mentioned. Thank you for the invitation. I am the health director and public health division director for Arlington County. So I am going to try to frame the discussion of disparities in general because there is no one place. There are many places that disparities and inequities can develop. And I want to make sure that this community realizes there are many places to intervene, and we should not be hopefully only intervening in one place. And if you intervene at the downstream level, the ability to actually reverse or prevent harm actually doesn't happen. Doesn't mean we don't do prevention from the treatment. However, we need to sometimes move from treatment to prevention and have a larger model. So with that, so this slide I actually created in 2021 during the middle of the pandemic. At the time, we ranked #1 in the state rankings for Virginia for the Robert Wood Johnson Health Foundation. With Loudoun and Fairfax, we've changed places among 1, 2, and 3 since 2011. The difference between years can often be to 1 infant death. Okay, that's both sad, and it also shows how close and how healthy in some ways Northern Virginia is, not just Arlington. In 2003, we ranked 3rd. I think it is safe to say we're a healthy community, or can we say that? So a little bit of history. In 2007, we had launched a program called Destination 2017, we're required to do community health status assessments by the Virginia Department of Health. And so we recognized we were a healthy community compared to others, but there was limited data. You had to piece together some things. And so what the committee at that time focused on was improving health and well-being by promoting healthier behaviors and reducing health risk factors. So we focus on things like childhood obesity, sexually transmitted infections, influenza, tobacco use, and substance abuse. And I mentioned the Robert Wood Johnson Health Foundation data that gave more of an apples to apples or orange to orange comparison, but it was still at the comparing cities and county level as opposed to within a locality. In 2017, it was the game changer. The Northern Virginia Health Foundation, I give kudos to their soon-to-be retiring head, Pat Matthews. She commissioned with VCU in Richmond doing a project to actually look at life expectancy and trying to do it at the most granular level within each jurisdiction, and was able to identify islands of disparities in Northern Virginia by census tract. So in fact, while Arlington overall still enjoyed good health, that's when we discovered what you'll see on this next slide, which is the cover of our report, Destination 2027. And it gives the punchline away, which is fine. Life expectancy, who you are and where you live can make a decade of difference. To think that from Roslyn to Ballston, or from Aurora Highlands to Ballston, there's a decade of difference in life expectancy, that should capture your attention, okay? You'll see in the next slide that the average for the county is 82 back then. Pretty good. But when you disaggregate it, now there's a range. Remember that stuff in basic math where you had a mean or an average and you had a range? We hope that the range matches up with the mean. That would be, in a sense, what I try to remind people. If you want to see what would be equitable, let's hope that everyone roughly on a population level was all at 82. Now, I'm not going to begrudge anyone's at 88, but how many of you want to be in the area that may be 78? Is there something that may be there? So those are some of the things that you have to think about. Because, and this goes to the point, averages often hide disparities. It's very easy to just say, I'm sure everyone has the same experience. But looking at the slide right above it, you know not everyone has the same life expectancy experience. And so this is another way to look at it. You've got the same information now about life expectancy. But on the next slide, you start thinking about the community conditions. What are the conditions in those areas of the life expectancy? And they're not the same. This is one example, and obviously there's great to have lots of data, but this is one of the data points we had. It's talking about the percent of children living under the poverty level by census tract. Now, it's not an exact match, but there's overlap, as you can tell, between some of these areas. And you will start seeing that more and more, that there's overlap between like the outcome and some of the, I don't like calling it this, but for this purpose, the process that may surround it or the environment that may surround it. So the group for Destination 2027 concluded the 10-year decade of difference in life expectancy, depending on who you are and where you live. Populations likely to experience that poor health outcome or disparities include women, people of color, low-income residents, the LGBTQIA plus community, those living with disabilities, in addition to those living in certain geographic areas. And often these groups intersect, okay? It's just how we do things. I don't like using the term, but we have a way of separating or segregating ourselves in society. It just is the reality. And it's not just here. It's how human beings do it across the globe. I'm going to go over my time, but I'm going to use this example. I'm anticipating. So yeah, some of you may not be aware of the Whitehall study that was done in the United Kingdom back in somewhere between the 30s and 50s. And that is a study that looked at stratification in the United Kingdom. And remember, at that time, race was not really a factor on the British Isles. So I think we all think, oh, it must be that. It's not just that. We can stratify, and when they looked at class structure, I'm going to make this up, royalty and the next level, you would think that they'd be close. They're still a step. Okay, we find ways to make gradations about how we organize and how our health and outcomes turn out. So disparities exist. This matters. This is not okay. And one of the things that the committee thought that this community would believe it is, we may not have created the existing conditions. Most of us were never here when some of the policies and other things were here, and yet we all own solving this. So these are some of the community conditions that we looked at. And if you look at it, it lists education, environment, neighborhood, social connections, economy, housing, and healthcare. And notice healthcare is only one of those options. And in our experience, healthcare is usually not what's going to save life expectancy, quality, or quantity. Because by the time you're thinking about life expectancy, which is usually at the end, you can't increase it significantly, both quantity and quality. If you want better quality and quantity of life expectancy, we have to start moving upstream. So that if you're talking about things like women's health, especially say maternal child health, you've got to do it before they're at risk for becoming pregnant, okay? Because once you're pregnant, you can reduce the harm, you can't erase the harm. In which position would you rather be in? Not having the harm at all, or hoping that the doctors, even if they're fully aware, can stop it in time? So this is the back cover of the report, and you'll see there's a definition of health equity. Exists when everyone has access to the community conditions needed for optimal health and well-being. Catch up to my own notes to make sure that. So we see the definition of health equity. You'll now see the diagram that says equality versus equity. And this is a diagram from the Robert Wood Johnson Health Foundation, the ones who did the county health rankings. And it's a way to actually explain the difference between equality of opportunity and equality of outcome, okay? When you have equality of opportunity, you notice that, and these, imagine the four purple people represent populations. They're not individuals, they're populations. If you give the various populations the same way, you will see that only one of them can journey to health, if that's the goal, without risking significant injury or harm. Kind of a horrible thing to think that on your journey to health, you may actually injure yourself. Three of them, one may not even be able to move in that direction, and the other two may actually get injured on the way. Is that what we want? That's what happens when it's a one-size-fits-all mechanism. Equality of outcome, which is often now what we call equity, you're giving the populations what they need to get to, if you say there's a shared goal, equality of outcome. And this would reduce the risk of injury on the way to that journey. And the way to kind of assess these things is by the questions we ask, okay? It may seem kind of like simplistic, but we're talking about behavior change in all of us. Because if we're looking at equality as the true frame, then we're going to be asking equality of outcome if you want equity, because equality of opportunity does not ensure the same outcome. And if we're invested in ourselves as a community, we want the outcome to be pretty much similar, because remember, there is some self-interest if it's not just for the other, and we'll get to that. So the questions we can ask: who benefits, who is burdened, who is missing from that equation, and how do we know? And the reason why how do we know is important. We have got to stop doing thought experiments, because that's where, oh, I'm sure we know. That's not how science works. If you want to really change things, you need to ask, how do you know? And then asking that when you're making decisions about our policies, programs, procedures, and budgets all the time. Whether it's at your small organization up to, as some of the folks in this audience may know, being a member of a board, okay? You can't always do everything, but you've got to ask people and just not assume, I'm sure the outcomes will be fine. Find out what are the barriers, and are you okay with those barriers being present? Sorry. Now notice I've crossed out the word health in front of equity. I started this project and launched it with health because people would wonder, why did public health take this on otherwise? We've got to realize equity in all of the upstream policies, procedures, budgets, and decision-making is what leads to educational health, health itself, and equity, and so on. So equity, and you'll see it more in some of the logic models, equity in a lot of the things we do as society is what leads to the various types of health. So we've got to stop putting health in front of it, because what happens the minute you put health in front of it, everyone knows that I must have the prescription for that. When the prescription pad actually is in everyone's hands here and outside of here. We've got to have that frame, because that's when you hear about social determinants of health, it's not being social. It's you should probably say societal determinants of health. Society, who we're a part of, makes the decisions that impact health. So here's a way that a group in San Francisco thinks about health and risk factors, both the downstream and upstream effects. And I'm going to deconstruct it. It's my Top Chef moment. So downstream, I've said, mortality, life expectancy, and infant mortality. Doesn't mean there aren't interventions that can help to extend it, but we're not going to, on a population level, change people's life expectancy if all of the interventions are here. Okay, I think that's fairly intuitive. We often have disease and injury happening before mortality, so you can intervene there, and that's what often folks at this hospital, when you go to your doctors and nurses, they're helping to diagnose and treat or prevent disease and injury. But once again, when you get to this point, you're not going to have as long an ability to change mortality. We know that risk behaviors, if you don't wear a helmet while you're riding a motorcycle, if that was a whole population, you could end up having a lot of injury that leads to death and so on. So you can start doing things at the risk behavior level, campaigns on smoking cessation. But that only gets so far. Once again, you'll notice some people have targeted certain marginalized groups to smoke more than others. That doesn't help if you're looking for health. You can always do differential things for each of us. It's linear, and yet it's not. Okay. Living conditions. We've talked about living conditions again. So our policies, local, national, in between, determines living conditions. The institutional policies and social policies, and if they're biased or not, can lead to differential access and differential conditions. So another way to look at it, if you don't like the linear, think of this as nesting dolls. Okay, I've decided to use penguins rather than Russian dolls. But the point is, death, we're never going to really ever get rid of it. But if we can push it down as far as possible to have the longest quantity and the most quality, I think everyone would like that. But think of that as within the context of each of these others, okay? And that context is what helps determine a lot of health. Most of us do, or many people do not have the choice of which context bubble they're in. So which of these three contexts do you want to live in? The red penguin dolls, the yellow or the green, which would be like traffic lights? Which one would you want? Because the likelihood is life expectancy in the end is shorter or longer depending on which one it is. We talked about needing to work upstream. The pre-COVID assessment was disparities exist, this matters, this is not okay. Now COVID and beyond, disparities are worse, this matters, business as usual is not okay. So we need to think about equity on our policy at all levels and revisit it. I use this as a way to say, we're focused on women, I think, for this, but the more we can think about how we can do things that help the marginalized, as well as, so if you can't see the slide, it's a depiction of after a snowfall, there's a ramp and stairs to be shoveled. And person one says, could you please shovel the ramp? The other person says, all these other kids are waiting to use the stairs. When I get through shoveling them off, then I will clear the ramp for you. Rejoinder is, but if you shovel the ramp, we can all get in. Now, I'm not going to be able to say that everything will always work out like this. However, I think there are more of these than we can be creative about, that we want women to be healthy. I don't think women want to be healthy at the expense of not their children. Remember, the minute single young men turn 18, they're single young men, they are still someone's children. So what is in your and our vision of equitable conditions and comparative health outcomes for health? This is what we're at. Sadly, you could actually have equity and it could be all bad. I'm just pointing that out. Some people will opt for that.
I want to bring them back a little history for you all. And this is a picture of my dad, Dr. Roland Bruner. He graduated from Howard's Med School in 1932. And he came to Arlington in 1934, built the house that I grew up in, which again, thanks to Arlington Housing Corporation, they've memorialized that. And he's got a great plaque on South Lee Road. I grew up, excuse me, on 2018 South Lee Road. But at that time, you know, we can't forget our history, because if we don't know our history, we don't know where we're going. And things were segregated then. And there were no African-American physicians to take care of the population that was here in Arlington. And my dad, as I said, he established his practice in 1936, and you all may know a wonderful activist, Dr. Alfred Taylor. My father delivered Dr. Alfred Taylor the first month he was here, and at home. Okay, so just a little factoid. I'm going to give you a few more. But anyhow, at that time, Arlington County, the health department, hired him in 1938 to take care of African-American women. And, you know, again, things were segregated. So where was the clinic? It was in the jail. Okay. And, you know, and that's where he had to take care of people. So this is one of the pictures. This was taken in back in 1938 or so. And he was very instrumental because he was very passionate about women's health. And in fact, he taught OBGYN at Howard University and basically until 1951. Even though he wasn't a gynecologist, he was a general practitioner, and he could do it all. And in fact, my office manager of 25 years, she's retired now. He delivered her at home. Camille Collins, and you might know Yolanda Black, that name, that was her sister. But again, we're all a really big family. So, but he really believed in women's health, fought for women's health, and delivered the care. And the clinic was moved. It was still moved in Green Valley. He had that clinic. And he practiced in our house in South Lee Road and in the clinic till the week before he passed away. And he passed away, I'm wearing of a heart attack. Now, interesting story. He was having angina, so that's, you know, chest pain that could precede a heart attack. And I will never forget, I was a medical student then. And we called the paramedics. Now, this was in 1978. The paramedic was so nasty to my father. He said, I'm not going to the hospital with it. And he didn't. He lived another couple of days, but he still had ongoing angina. And he wouldn't come to this hospital because of that. He went over to, the hospital in Washington, Providence. because he said, doctors are horrible patients. He said, I know it's my gallbladder, and I'm going to get my friend to take out my gallbladder. That's it. And so, I begged, come on. And so we went. And again, I was a medical student, 3rd year, but I knew a heart attack when I saw it. And his EKG was horrible. And I won't forget, the resident came out and said, your father, we've given him as much morphine as we can. Can't give him any more. And I looked at him in the eye. I said, the first thing we learned is if a person's having pain, you get them out of pain. So give me that syringe and I'm going to give it to him. So he went back and did. So, but anyhow, unfortunately, my father, did not live. But what's an interesting legacy, he touched so many people in Green Valley. And I was so happy. I was so happy to go to medical school. I couldn't quite follow in his footsteps. But again, I wanted to continue that wonderful legacy that he had. And another factoid, I ended up dating a man who I married. He worked for ExxonMobil. And his admin came in the room one day and said, close the door. Who is this Denise Bruner that's calling you? And she said, well, is she related to Dr. Roland Bruner? And he said, well, yes. Well, she said, half of the admins here in the building wouldn't be here if it wasn't for him. So that's my little factoid stories, but he's with me now. But I will tell you another thing. Arlington Hospital was segregated until the mid-60s. And if you were a person of color, you were out, if you got here, you were out in the hallway with a barrier in front of you. And if you had to go to the hospital, you went to what was Freedman's Hospital, which was then now Howard University Hospital. So when Arlington Hospital, and I'm so proud of it, desegregated, and they said, Dr. Bruner, do you want to be on staff? He said, if I wasn't good enough for you then, I'm not good enough for you now. And so very much a man of principle. So I'm going to segue, if I can, after I tell you. Oh, and by the way, I worked in the health department from 81 to 83 in family planning and in the prenatal clinic and in pediatrics and in geriatrics. Did a lot. But I just want to touch on a little thing, and we'll go through this very quickly. And we talked about, again, determinants of health, health equity, mortality. Well, obesity is is the greatest preventable cause of death that we have right now. And we're looking at this by race, and you see there's a disparate amount of women, African-American women, who are obese. Over 50% of African-American women are obese. And if we think about obese and overweight, 4/5 of African-American women are affected by this disease. So we're not going to go through that. It's boring numbers. You can look them up. Classification doesn't mean much. If you took Serena Williams and did her BMI, she'd be obese. So it doesn't tell you a whole lot. So anyhow, this slide says 229. There are actually over 260 conditions which are touched by obesity. Okay. And again, old physics, fallible logic, calories in, calories out. How many times have people told you that? Oh, I almost said a bad word. That's not correct, okay? Okay, because we used to think it's just what you take in and what you burn, okay? But we all are biochemically individual. So we all have different metabolic rates. We all have different activity levels. So it doesn't matter. And we have other conditions that impact how our body perceives the calories we take. So again, looking at some really things that we want to be proactive and prevent things. So if we lose 5% of our body weight, we can improve our blood pressures. Simple. Maybe eliminate some medicines. That's great. Or a 10% reduction in your weight, you can improve your cholesterol, your triglyceride level, or even prevent diabetes. And a 10 to 15% weight loss can certainly improve cardiovascular disease. Again, number one killer of who? Women. Okay, and more than 15%, you can prevent type 2 diabetes. This statistic is really frightening. That 58% of Black women over 20 have high blood pressure. And that only 20% of them have their blood pressure controlled. Why? Because we as ladies, we do it all. We can just, we cook, we clean, we're doctors, we do all this, but we don't take care of ourselves. So again, about 13% of African American women have diabetes. You're going to have eye problems. You may have kidney disease, kidney failure, amputation, more risk of cardiovascular disease, and premature death. Not a good thing. Again, another factoid, 50,000 women die annually because of cardiovascular disease. Again, you see a correlation, 59% of Black women over 20 have cardiovascular disease. What if we looked at the statistics of obesity in women? Kind of parallel, right? And before menopause, women really are 50% less likely to have heart disease, but after menopause, the rate is about equal. So what are the factors? And it's interesting, we talked about the factors contributing to overall health and health equity, but we see, again, somebody says, well, I can eat all this and I don't gain any weight. And somebody else says, oh, because I had one of my friends was a psych resident. My God, she ate 24/7 and she was like 100 pounds. I could kill her. And I was like, what? I was like, I'm struggling, okay? But there's so many environmental factors, but the main one is our genes. We can't pick our parents. So we don't know, we can't control that at all. And sometimes we can't control our environment, just like we saw Dr. Varghese said, where do you live? And what is a life expectancy? Sleep is a big thing. Nobody gets enough sleep. And, we live in an area that's full of stress. So that plays such an important role in our overall health. And, as doctors, we give lots of medicines. We're trying to help one thing, but hurt another. I remember when I was at DC General and Clinic, again, nobody talked about weight. It was just willpower. You just need to eat less, push away. And I remember in my diabetes clinic, you saw people continuing to gain weight, and all you did was give them more insulin, more medications, and they got fatter and fatter. So that's when I said, wait a minute, this is madness. This is why I got interested in obesity, because again, getting at the root cause. So just some helpful principles. One of the things I saw today, we're all sitting too much. So let me show you. So again, we be sensible. We want to have healthful things, but then there's the equity. Are the stores available to give you those things? Is it affordable? Okay, those are the disparities. Do we have safe places to exercise? And we know, God, we can just go down Langston Boulevard. What do you have? A Taco Bell, McDonald's. Everything is so quick, easy, and full of calories. So again, just trying to be sensible about intake. And nobody has to weigh because I love it. People come in and say, hey, Dr. Bruner, I want to weigh what I weighed in high school. I'm now 50 years old. I had 8 kids. And you're like, really? So anyhow, but again, some very simple principles to help your health is get your sleep, 7 hours. Didn't happen for us, did it? In residence, didn't happen. Because when I was a resident, also I had a son. And basically, I think I got maybe an hour every other night. Okay. And again, I was at I call it the General, DC General. There was no good food around. And so, again, my mission about obesity is when I was there, I gained almost 80 pounds because of all of those things. And again, just activity wasn't a whole but big part of what I did. But we have to drink lots of water, or I said liquids, but not necessarily alcohol. Okay, try not to smoke or vape. And, really, again, think of Hippocrates' quote. It's, let food be thy medicine. So, I wish you all health, longevity, and thank you for listening.
Are you accepting patients still? Because I would like to be your patient. Okay, great. And I have a walking desk. I want to make you proud of me. So, in my office. I made pretty slides for you, so I really want to show them to you, and I hope you like them. And I like your style, and they kind of match your style. So. While we're troubleshooting, I'm going to tell you my interview trail joke from fellowship. So my last name is Mwasegwa now. My husband's from Uganda. My first name's Patty. My maiden name was Leek, so I grew up P. Leek, which was super fun. And now I treat incontinence and prolapse as my calling. I should have kept my maiden name because it would have made for some sweet marketing, but now it's too late. And my mother would kill me if I changed it back because she'd think I was getting a divorce. Do a hard restart. If it doesn't work, I'll go through them because I can see them and I'll tell them to you. Yeah, nobody wants that. I'm good with a scalpel, not with a pen. Okay. Give it like 10 more seconds. Was it thinking? Was coming up? Yay. Okay, great. Awesome. Well, did I tell you it matched your style? It matches your style. My name is Patty Mwasegwa. Thank you so much for your precious time. I really appreciate it. These are my slides. I was asked to share a bit about my experience as an OBGYN and now urogynecologist with the maternal crisis that is being a woman in America. So this is my daughter. This photo is me and my daughter. Her name is Muriel. She was born while I was a first-year fellow, about 6 months into fellowship at UCLA. The process of being a female physician, taking care of women, being expected to work like I had no child and mother like I had no job, it pretty much killed me. I'm really grateful for a lot of healing processes, but when I look at my female patients, especially my Black female patients, I think about what my daughter's experience might be like in America. It scares me. I think about how much of a bulldog I'm going to have to be in the labor and delivery room with her as a Urogyne, as an OBGYN, making sure she's safe. So a lot of why I care is motivated out of fear. to be honest. And I know too much, and I've seen too much good and too much bad. But here I am. So these numbers are general for the USA. I'm bi-coastal, just coming back here from 5 years in California, so I can speak more in general terms, less in Arlington specific terms, so please forgive me for that. But our numbers as of 2021, this is the most recent CDC data, our numbers are really bad. We have 33 maternal deaths for every 100 live births. It's increasing, which is the opposite of what should be happening, and 10 times the maternal mortality of comparably developed countries. And it is worse for our Black mothers in America, 3 times as worse, or 3 times as bad. That's not grammar. But total maternal mortality is on the left, 32.9 per 100,000. Black mothers in America, 70 per 100,000. White mothers, non-Hispanic white mothers, it's 27 per 100,000 die, not just complications. These are dead moms. What I see as a Urogyne, I'll just share, from some of my experiences with patients. I see a lot of them coming to me after the fact. In my specialty, I tend to deal with the way later trauma, perimenopausal, postmenopausal, pelvic floors. A lot of patients sharing, I was never told the risks of delivery. I can't speak to what they were or weren't told at the time, but I have been in very high pressure situations through training. I started out my training wanting to be a labor and delivery hospitalist, deliver babies all day, every day. And by the end of residency, I went into Urogyne, which is pretty much as far as you can get away from that, because I was so crushed. And I have so much respect for people that still do that every day, all day. I do not have that stamina or that bravery. I do know what it's like to be a mom going through that process on the other side as a patient too. But I hear a lot of minimizing of childbirth risk. We're taught that it's normal. We're taught that it's, there's natural delivery, which is vaginal delivery, natural delivery, and there's C-section. And when I ask my patients about their surgical histories, a lot of them don't even include C-sections on their surgical history because they don't think of it as a surgery. It's a laparotomy, an exploratory laparotomy, where you get a human being as a prize to take home. It's a big deal. And reframing that C-sections, pregnancy, vaginal, all of it's a big deal. And we are taught that, it's very minimized in our society. And that makes me deeply angry, if you can't tell. I also see from the doctor to doctor standpoint, when I was a resident getting consulted in the ER overnight, or a fellow getting consulted in Urogyne, a lot of people look at pregnant people like super dangerous time bombs with an extra little time bomb inside. And there's 2 for the price of 1, double the risk, half the fun. And treating conditions is extra scary. Nobody studies, very few people study pregnant patients for medications because it's too high risk and pharma doesn't want to pay for that. And patients probably don't want to participate in that, and I can't blame them. But there's very limited data available for safety profiles of certain medications because nobody studies us. And until recently, women weren't even in general required to be included in study populations as half the representative. So evidence-based medicine it's men-based medicine. And women are not small men, to quote one of my favorite human beings, Kelly Orzakowski. She is the chief of the women's service line here, and she is incredible. But there's a lot of fear about do no harm is our first job, right? But sometimes you got to be a little bit brave and not just push things off for treatment until the end of pregnancy and after the fact. A lot of the health conditions that Dr. Bruner spoke to so well, a lot of that I've seen kind of get tabled till after someone's no longer pregnant. Well, postpartum is dangerous too. And it just kind of gets pushed off. Postpartum mood disorders. 15% of women will have a diagnosable psychiatric disorder in the postpartum period. And you know how many postpartum visits most women get? 1. or zero. And the postpartum care, the global package with insurance, I don't even practice OB anymore, but insurance treats from the time you have a diagnosed confirmed pregnancy until 6 to 12 weeks postpartum as one thing. And that gets reimbursed to the delivering doctor only in general as one payment. That does not encourage people to see you often for whatever is bothering you while you are pregnant or postpartum, if there is one lump sum payment for the whole period. And I think that is a big flaw societally, and don't get me started on insurance. Legislation is way behind. 2021, kudos, Virginia finally extended postpartum care for our Medicaid and CHIP patients through 12 months instead of 60 days. That is big progress. But that was 2021. That should have been like 1950, 1960. But slow legislation and quick return to work in our society. Most families I know could not live the lives they lived on one parent's income. I can't even tell you how many of the patients I see have gone back to work at 2 weeks, sometimes less. I went back to 5 weeks after a 3-day induction, a C-section, impossible breastfeeding, and super depressed postpartum. And I'm a doctor. But quick return to work. We're expected to mother like we have no children and work like we have mother like we have no job and work like we have no children. This article is available online. This is written by a friend of mine who I respect greatly. Her name's Jocelyn Fitzgerald. She practices at, as a urogynecologist as well. And she focuses on providing informed consent for the pregnancy and delivery process in this article to patients, and how educating women is not going to deter women that want to have children. You will just have more educated women with knowing what's going to happen with the process, the risks, who to go to if the risks happen to you. So, okay, I'll be positive and less angry. So what VHC is doing to be of service to women. We have double board certified maternal fetal medicine experts who see patients for antenatal preconception counseling, like before you're even pregnant, try to minimize health risks before you are pregnant. And they can see our high-risk patients all through pregnancy. I'm a urogynecologist. I'm here to deal with after effects, planned or unplanned. We have expert OBGYNs available to care for our patients. The Women's Health Service Line. So I was hired as a part of this. I was hired to build the division of urogynecology within the Department of OBGYN within the VHC physician group. We provide urogyn and subspecialty care to also our Arlington Free Clinic patients. So our Arlington Free Clinic patients have access to subspecialists. Me, MFM, Gyn Oncology is joining later this year. So those patients have equal access. We also are opening a menopause clinic. I'm super excited about this. Half of the population will go through menopause. And if men went through menopause, testosterone would be in the water supply. But we now are opening a menopause clinic because adequately treating perimenopause and menopause can increase life expectancy by 2 years, decrease dementia, prevent osteoporosis. And I would like to tell people about it. We will have this clinic staffed by menopause certified practitioners. Doesn't exist yet, but if you want to see any OBGYN here or me, we can get you on a list to be called. And then pavilion access. So the beautiful pavilion that I'm super grateful to get to practice in. It's kind of an act of respect towards the precious time of women who are serving everyone else and then get to go to their appointments. So it offers everything all in one spot. I'm on the 5th floor. I share a hallway with breast health. Gynonc is further down the hallway. MFM is to my right. OB is further down the hallway. We're all there in one neat little package for people's convenience. And then what do I try to do with my patients, especially my Black female patients who probably have had some really bad experiences in healthcare before ever coming into my office? I actively invite them to have family members with them, advocates with them, people on the phone with them. Usually there's a family member or contact that's a nurse or a physician, and if they want them in on the conversation, I pause the conversation or hold the counseling until whoever they wish to have with them is with them. I respect the patient's autonomy and that they probably have reason to not trust me as somebody in a white coat. And I try to take the opportunity to prove myself to them, earn their trust. They don't have to automatically trust me. I will work for it. And my primary goal is to educate people on super uncomfortable topics: prolapse, incontinence, fecal incontinence, urinary incontinence. Nobody likes to talk about it. It's so common that I have a job. And I try to make it less weird and help comfort people. But I always think about what will my daughter's experience be like when she seeks care? How would I want somebody to treat her? And then I try to do that. Thanks for your time.
Thank you to all of our panelists. Do we have any questions? Any questions? Oh, you need to use the mic. Okay. Any questions?
I came to the AC. I
What was your question? Sorry. Well, so compounding, there is a little less. So the question was about compounded versus like typical prescription hormone replacement therapy. In general, I try to stick to standard formulations because of a predictable, reliable dose for the patient and a bit more safety in monitoring. When those don't work or my patients have an adverse reaction to them, some of them have alcohol in the bases and patients get a lot of skin sensitivity to that. I do then use compounded treatments in neutral bases or other options. But my first goal is standardization, knowing that there's a reliable, safe dose being delivered to the patient, and minimizing variables. I also, being new to the region, who you know is everything, right? Getting to know who does things safely and well. And so usually I find one reliable, safe pharmacist and I just work with them for compounding. I don't go willy-nilly. Right, yeah, I live right across the street from them. Can we get?
All right, can you guys hear me? So I'm giving a background to get to my question, but I was saying that I'm an immigrant. I came here when I was 11, and then my mother, she got pregnant, like 2 years into staying in America, and unfortunately, she had a miscarriage, and it was just horrifying the experience. Not only she was a Black woman, she was also an immigrant, you know. And to get to my question, you know, now that you spoke and told us about your daughter, as a Black woman, I can kind of, you know, come to you and trust you as my doctor. But if it wasn't for me attending here, I wouldn't have that same opinion on you, like very respectfully. So, what do we have in place for to hold nurses or doctors or anybody accountable so that I do feel comfortable, you know, because I'm 24, eventually I want to have kids, but one of the reasons I don't want to is because of seeing how my mother got treated when she had her miscarriage at the hospital. They removed her uterus. She had to have emergency surgery, but she didn't even get looked at until like 3 4 hours staying in the emergency room. So I want to know if we have any type of training for doctors or nurses that kind of lets them know how to treat women of color, specifically immigrants as well, because we have a lot of them in Arlington, especially South Arlington. That's where I grew up. That's where I went to high school. So to make a long story short, what do we have in place to hold doctors and nurses accountable so that I do feel comfortable coming to, you know, these places?
Thanks. Thank you for your question. I'm sorry for your mom's awful experience. I don't know the metric ways of what, like who has to do what to show that they are accountable here yet, just as a new hire with the onboarding, or the like, you know, the annual modules that most hospital employees have to do. I think the true answer that I use when I'm looking for somebody to make sure they're a decent human being is word of mouth and who can I trust. But I think something like that does exist here, and I will find out. I'd like to get your contact information and I will follow up with you.
And another addition to that comment is, no matter who you go to, make sure you pay attention to how they treat you, because how they treat you tells them you an awful lot about them. Okay? And so be your own advocate. And if someone is, I don't care how credentialed they are, where they came from, what their office looks like, if really they are not making sense, they're not speaking to you, they're not listening to you, find another provider.
Google reviews. I use Google reviews for a lot. Because people can write their honest opinions there too.
To pile on, but I think it's an important thing. A lot of people I've seen in all walks of life think that if they've talked to a doctor, they need to stick with a doctor. You do not have to. It is a pain in our system. I will not deny that. But when it's your health care, if your gut is screaming, listen to it.
Yes.
Yay. Go Bisons.
Yes.
Mhm, 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 mhm. Sure. Mhm. Well, okay, yes. So anyhow, basically to answer your question, having high blood pressure leads to a myriad of medical complications. It leads to perhaps stroke, death, heart attack. It leads to, again, blindness. It leads to different vascular diseases. I mean, it's a myriad of things. But again, we understand high blood pressure is a silent killer. So most importantly, you need to make sure you get your blood pressure checked because that's what people don't know, okay? And doing very simple things in terms of regulating, because we as African Americans are more sensitive to sodium. And so regulating sodium in our diet, getting adequate hydration, getting adequate rest, those are very simple things that don't involve medication, okay? And regular exercise. So go ahead, now tell me.
And then my second question is about the 20% who do have their blood pressure under control. And as I'm looking around the room, this really is more so like a collective question. So what is it that we can do to increase the threshold of that percentage?
Okay, the slide was 20% don't have a control, don't have a control. Okay, but anyhow, okay, all right. But basically, again, it's just being proactive with your health. Okay, have your regular checkups, do those things, those simple things. My father had a patient, and up until the day she dropped dead, I would see her walking on Langston Boulevard. Her blood pressure was perfect. She was an 85-year-old woman, walked every day of her life. So, again, it's trying to have, you can't escape our genes. We understand that, okay? So that being said, you can only mitigate those risk factors and being proactive, and again, having proper care, okay? Don't accept second rate.
So we have 3 questions that came in online. I know we don't have a lot of time left. So I'll go ahead and do one of these and then I'll let you all both do yours. So one, and there might be some audience members can also answer this. What priority level does the Arlington County Board give to health equity in making development authorization decisions? Do you know, John? Okay, we'll try another one. Yeah.
The county board, after our efforts, did adopt an equity resolution, not a health equity resolution, but that should cover those things. But you'd have to direct those questions to the county board for that sort of discussion.
How is VHC addressing the disparities in prenatal care to ensure that everyone has access to the best and safest care?
My disclaimer is I don't do OB, so I don't actually know the numbers. I believe, so when I was in residency here, 2014 to 18, we, in our resident outpatient clinic, which still exists, is very active, we would have patients from DHS, Department of Health Services, that would come to see us around 39 weeks or so, and they would transfer their care and then be delivered at VHC. So we would do their intake visit, and then they would deliver in our labor and delivery. I don't think that answers the question about access throughout, that doesn't answer the question about access through the whole pregnancy. But that's the most I remember.
Since I represent DHS, it's my clinics that pass it off to you, all of you. We follow the ACOG guidance, and so we offer that fully through the county, and then it's non-high-risk patients that get transferred at the latest. High-risk patients, the minute they're diagnosed, it's within 2 weeks or less that they get transferred to the hospital. So that is something that is routinely done. And then, of course, we look into the hospital for any premature births and so on to see whether anything that we could have done during the process that we missed. Typically, we haven't seen that, but that goes to my comment about all of this. I'm glad you're focused on clinical care, but you do realize all the risks that happened before they came to the hospital or to us has already occurred. So we won't solve it tonight, and yet we should not be running away from the fact that Serena Williams had exposures before she got to a hospital suite. Are we concerned about that? The women with high blood pressure in certain groups, if they're having the stressors compared to other groups that are higher versus others, if you don't change that, yes, glad they're medicines, but your risks that created the stressors are still there. So those are the things that this group, if they care about it, need to advocate for the discussions, because this is not a we'll just get it done. Just having done COVID, I've also recognized what happens. There are different opinions on health.
We have several people that still want to ask questions. I am so sorry, but we are already over time. Okay.
I'll make it really quick. Thank you. This question is from Ms. Garner. So I wanted to know, what would you recommend for women that are struggling with health conditions like PCOS? And you know that's a leading cause for obesity as well as weight gain. What would you recommend them to do to not only tackle that, but also be able to possibly reverse it?
Polycystic ovarian syndrome. That's what it is, and it's not uncommon. And it's one of those like 229 entities that I talked about up there. A lot of times PCOS precedes or happens concurrently with prediabetes or something called insulin resistance syndrome. And so again, it's very important to be screened for that because there are certain and very appropriate medications to be prescribed in addition to specific food plans being protein centric, limiting or controlling carbohydrates, but again, in physical activity. So those are all very important things, but the baseline is the food plan, the physical activity, and then if appropriate, there are specific medications that can be used.
Good evening, everyone. Thank you all panelists for sharing your story and the work that you all are doing in this community. My name is Christian Christian. I work as a public health advisor with the CDC, and my division actually works with local and state health departments. I don't know if you all are involved or connected to any federal funding, but I know that my division in particular supports a lot of the efforts that you all are doing. And we do also have a grant opportunity that will be coming out in April of this year that supports a lot of the work that you all are doing. So a lot of my work focuses on community collaboration and outreach. So if that's something that you all would be interested in, I know that our department would love to support. I just, before my question, I would say I'm board member of the Committee 100, and I think I speak for all the board members saying thank you for that. That was a real great benefit of tonight. I wanted to ask, we talked a lot about what's not going on in the United States. Are there any countries that are doing maternal care well? And I know we're limited on time, but just briefly, what is it that they are doing well that makes them stand out?
Thanks. I'll be honest, my answer for most of this comes from everyone I follow on Instagram. But Finland, Denmark, a lot of the European countries, the paternal leave, maternal and paternal leave, time to bond with your baby, time to get breastfeeding established well, not being rushed back into work. The European countries in general, but I think Finland and Denmark stand out.
I would concur. I think what you have to remember, this goes back to what environments we create. We don't create environments that support community activity to care for themselves. We believe in STEM, and every time I talk about why don't we have more healthcare providers, everyone's like, that's not supportable. I'm going, why not? It's a question of, this is me as a citizen. This is what we have to decide. Are we prioritizing the care of mothers and children and so on? That there's only one way to do that. You can't do the efficient thing and say there must be a pill that can get rid of all of that time and effort.
Last one, yes.
Hi, good evening. Thank you so very much for your work and for your efforts. I'm coming as a Black woman in America and also a resident of Arlington. I'm actually working with DHS right now as the Executive Director of Challenging Racism, and we're talking about the intersectionality. And so my question is, how are we working with other areas within the community to make sure that people have the resources, know that the menopause clinic is coming, and what are some of the efforts that are happening within the county so that other people are aware of what are some of the resources that they can obtain?
Well, it's going to be forums like tonight, and then as we connect with people sharing things, because there is no clearinghouse, because every time you try to create a clearinghouse, it's an interesting phenomenon. And so we're happy to share this information in these sorts of forums that we have to keep interconnecting with each other. But the problem with that is if it's all relationship based, which is a very important thing, it means that if the relationships break, because people change and so on, then it gets redone. Anyone who has suggestions on that, we're all ears. It is going to be one of those things where, though, we have to be plugged in as often as possible. And what we're trying to shift from public health for pandemic planning, while we have relationships, we're trying to see how do we restructure so we can be more embedded in the community and not just be a couple of outreach workers. Because remember, if a couple of people do it, I used to say, what if they die off extra staff? So can't you make it that they won the lottery? Fine, they've won the lottery, you still have lost the capacity. So trying to shift towards having a community health outreach mindset and say, of my 150 staff, maybe 100 will be doing some of that work in the community. That will be harder to disentangle, but that's going to take time as well. It's a good comment.
So thank you all for coming. And I think we each have a responsibility to use our circles of influence to get this information out into the community. So thank you all for coming. We'll see you on March 13th.